Hi, Dr. McGivney. How are you?
I'm good. How are you doing?
Good. When we present, do we just share our screen?
Sure.
All right. Thanks.
How are
I
things
think,
your way?
hmm?
How are you doing?
I'm doing good. I'm doing good. It's a
Mhm.
beautiful day out there. A little chilly, but nice.
Yeah, it is. At least the sun's shining.
I know. I kind of like it.
Yeah. It's a little bit chilly for me. I like summertime.
Yeah. Well, it put me in the mood of the holidays. So
Well,
I
that's
have
true.
all, I have my kids coming home, and so it'll be nice.
Oh, good.
Yeah. Yeah.
Hello, everyone.
Hello. How are you?
Good. Looking forward to your presentation.
Thank you. Thank you for the opportunity.
I'm excited.
I was there yesterday. I saw you
Oh,
all.
oh, good. I thought we had a very productive meeting, and I'm encouraged about the future for mental health in the state.
Me too. Me too. I think we'll be in good hands. And yeah, good work on behalf of all the committee chairs yesterday. It was a long one.
It was. Margaret, are you there? Hey, Margaret. I see your picture with the flag and everything. It's very impressive.
Is that the seal of the state of Georgia?
It is.
Dr. Lukowitz, are you back in Augusta?
I am. I'm in my student affairs office at the medical school here in Augusta.
So you just came up and back yesterday?
Correct.
My brother lived in Augusta for a long time, and I remember doing that trip from Atlanta to Augusta. I
If
have to
I'm
say,
not- if
it's
it's not-
boring.
Well, I just listen to NPR and I'm happy.
Yeah, it's a boring trip.
Yeah. It's not a bad trip. I've done a lot worse. All right, let's see. I've got 3:56. So we'll give people an opportunity to get here.
Hey, Margaret.
Hello.
Hey, I think I have my video on. Can y'all see me?
Yes, we can see you.
Okay, good.
And do you all prefer we'll turn off our videos until it's time for us to speak, and then we'll share our screen? You don't care, it doesn't matter?
Whatever you prefer.
Okay.
I sent Ashley my PowerPoint and asked her to run it for us.
Oh, I have mine here, so hopefully we can share screens.
You should be able to. I can see a share screen button on my screen.
Okay, yeah, I think I just have to be authorized at the time, maybe.
They won't let you do that right now?
Not now, no, but it says you cannot share screen while other participant is sharing, so.
Oh, they're sharing the House of Representatives. That's what that is.
Oh, I see the note, yeah, okay.
That's right. Okay, Media Services is sharing the screen. That's what that is. Got it.
Well, thank you. I'm going to turn myself off and mute myself for now, and I look forward to learning from everyone today.
All right, let me see who's here. Looks like we're about that. It's about that time. I'm getting on the list here. We're up to 9, so I think we're good to go. All right. Well, welcome everyone, and it's my pleasure to welcome you to the November meeting of the Behavioral Health Innovation and Reform Commission Subcommittee on Children and Adolescents. And without further ado, I'm going to introduce our first speaker. Margaret Kaywood, the Deputy Commissioner of Support Services for the Georgia Department of Juvenile Justice.
Good afternoon. Can you see me?
Yes.
Hear me? Okay. Thank you so much for giving us the opportunity to present today. And I just want to mention that our Commissioner of Department of Juvenile Justice, Tyrone Oliver, is a member of the commission and of this subcommittee, but he's unable to participate today because he's actually in flight returning from a national juvenile justice conference. And Dr. Christy Doyle and I will be presenting today, and she and I both have presented to 2 other of the commission subcommittees, the Court and Corrections and the Short-Term Care subcommittee. So some of this background information is going to be familiar to some of you. And then after yesterday's commission meeting, much of the information that was provided there and the recommendations, there's just a lot of continuity and consistency with our recommendations here. And we also have formatted our recommendations to lead with recommendations. And then Dr. Doyle is going to explain the why behind the recommendations. And then the final section of our background is going to be the background information about Department of Juvenile Justice, so that you'll have that even if we don't have time, doesn't permit us to review all of that. So if we can go to the next slide, I will start with the recommendations. Our first recommendation is about operationalizing the match committee, which is outlined in House Bill 1013, that it be convened and start staffing referrals for children with complex and unmet treatment needs. And just to have a understanding of why that's really important to us is that for young people that come into our system that need a secure residential setting and mental health treatment, have mental health treatment needs basically that are outpatient or residential, we do have the programming structure to meet their needs. However, for those youth with extreme complex and severe acuity that need crisis stabilization and psychiatric hospitalization, our system is not structured, staffed, nor code-directed to provide that or internally within our system, with the expectation that these children should have access to Georgia's system. And in thinking about yesterday's presentation on familiar faces, this really rang true to me because we in juvenile justice have a very small subset of youth with very, very high and complex needs. And that those are the ones that we really need additional supports around staffing and removing barriers so that they can have access to services. And we all know that it's not beneficial to a child or the system for us to push kids deeper into the juvenile justice system in order to access treatment services that they're not able to access in their community, or that they're charged with legal charges for their behaviors, which are symptoms of their mental health needs and disorders. Then the second recommendation is for DCH and DBHDD to revise policies and practices to recognize DJJ as a referral source for the PRTFs so that we are able to make referrals. We just recently had a case where we even worked with DCH and I think DFACS was involved. And the system is set up where it doesn't even recognize our clinicians or our clinical staff in order to do the referral process. It's as if the system was set up as no children that are in DJJ would ever need this service, which we know is not accurate. And then we also would request that DCH and DBHDD work with DJJ and emergency receiving facilities to develop direct referral process for DJJ secure facilities to access crisis stabilization placements. And this is pretty much aligned with the recommendations that were made yesterday about the expansion of crisis beds, that there's not only not enough of them, but the whole process of going through the emergency room to try to access one is definitely not working for juvenile justice children. Next slide, please. Well, we also have a recommendation about youth with developmental disabilities, that we do see quite a few of those children in our system, and we're requesting that there be communication and referral pathways for these services. And we actually had reached out to DD, and they have provided some training for us, and we've had some meetings about trying to understand their system. But basically it did seem to appear that there's not adequate services for any DD children, much less for those of ours that have the extra complex needs. And then for residential providers and residential bed capacity across the state, I think we've heard that across other subcommittees, that there's just inadequate number of beds or providers, and it does seem to be linked to the payment and to the way our system is structured. And for DJJ, we have a subset of kids that their classification and assessment information indicates they should be able to get their treatment needs met in a non-secure residential. However, because those beds aren't available, they're pushed into our long-term facilities. And then we also would recommend that we develop service capacity and resources for 18-year-olds as they're transitioning out of our long-term facilities, transition out of residential, and for those in the community that don't have access to those resources. Next slide. Another recommendation is around Medicaid and Medicare services, and that is to leverage the guidance that was provided by the Federal Center for Medicaid and Medicare to expand Medicaid coverage. And this was the January 19th, 2021 letter that was sent to the different states. And what our request would be is that to look at that particular flexibility that the feds are offering to expand coverage for justice-involved youth. And I know some of our specific recommendations is around justice-involved youth that have really high mental health needs, being able to have some type of care coordination or intensive case management when they're making transitions from one system back to the community. And then we also would like there to be earmarked budget increases for competitive salaries for our clinical staff. And as the information that was provided yesterday about DBHDD and the Community Service Board's clinical staff is very consistent with what we see, with a very high turnover rate, vacancy rate. And even with the $5,000 cost of living increase, that did not bring our salaries up to a competitive rate. And so in thinking about that from the state level, it really seems like that if we could think about all state and federal dollars that are going to provide any clinical services, that the staff providing that should all have comparable compensation, and not forget our part-time staff, and not forget contracted staff or any other type of staff that are providing the services. And I know for DJJ, we do have a large pool of part-time staff where we've had to cobble together services where we're not able to fill full-time, or a full-time wasn't cost-effective in certain areas. And then we also would recommend earmarking budget increases to sustain evidence-based treatment interventions and practices within DJJ, we have been using our general budget. Prior to the economic downturn, we actually had a specific treatment training budget within OBHES for evidence-based treatment, and that was cut. And so we have been having to pull from other pots of money in order to do that, but we need long-term sustained resources. So next slide, please. So why these recommendations? And I'm going to have Dr. Christy Doyle describe the challenges to accessing services.
Thank you, DC Kaywood, and thank you, committee, for allowing me to be here today. Next slide, please. As DC Kaywood said, we have a tremendous challenge with high acuity of mental health need. This has been the case in juvenile justice for many years, and part of the goal of the juvenile justice reform legislation of 2013 was obviously to help divert the lower need youth into community services and settings. This resulted in a distillation, almost, if you will, of the highest needs youth, which was what the legislation was designed to do. But because of this, that means a substantial proportion of the young people that we serve do have unusually high mental health needs when compared to youth in the general population. Although we don't have to attempt to access crisis services often, thankfully, because we do have a continuum of services in our secure facilities, we do occasionally have youth who have mental health needs that exceed the ability of the facility to support. For instance, a young person who may be experiencing severe psychosis, or a young person who is having severe and persistent suicidal thoughts, intents, and acts. In the past year, we've attempted to 1013 youth approximately 20 times from secure facilities, and only one of those attempts were successful. Of those attempts, we've had a young man who was so severely psychotic that he was unable to care for himself. We sent him to 3 separate emergency rooms. The first emergency room agreed with us that he needed care and attempted to access a crisis bed for him, but they were unable to do so. The second ER acknowledged that he needed care, but admitted that they did not have the resources to try to assist us. And the third emergency room called our chief of psychiatry, who was the referring psychiatrist, castigated him for a, quote, farce of a referral, and they sent the child back to us. Over time, we were able to connect with the young man's care coordinator from his insurance, and unfortunately, they were unable to access services for him as well. We discovered that, I'm sorry, next slide, please. We discovered that one of the challenges that we face is that the insurance providers, although they contract for crisis services, do not have any authority to actually compel a placement to accept a child. So in that respect, they are actually in the same placement or place that DJJ is, with going and asking, but having no capacity to actually enforce or demand. In addition, there are some fairly persistent misunderstandings in the community about DJJ capacities. One of the misunderstandings is that we are a crisis stabilization level placement, or PRTF level placement. I've had someone say in conversation, this young person's just too sick for a hospital. They need to be with you. They need to be in an RYDC. They're better off there. And I've had to reformulate the question and say, I want to be sure I understand. You're saying that this person is too sick for crisis stabilization, so they should go to jail. And have had people agree with that restatement. So there is some education that we in DJJ are attempting to do. In addition, there are some questions about our suicide prevention protocols, which we obviously work very hard on. And as a unified team, but those protocols are simply not equal to a crisis stabilization facility that is designed specifically for that purpose. Again, there are some misunderstandings about that. And unfortunately, there is a persistent narrative that DJJ involvement is an exclusionary criteria for crisis stabilization placement. Again, another area for education that DC Wood, myself, ABC Mance, all of us are persistently trying to help our partners understand. Next slide, please. So as we look at our next slide, as DCK Wood mentioned, in addition to crisis stabilization, we also frequently have challenges getting kids admitted to PRTF placements, regardless of whether they clinically meet the need for that placement or not. One of the challenges which she alluded to is the fact that the PRTF referral portal is designed specifically as a financial portal. I'll get to that on the next slide. But as a part of that, because our clinicians are not able to make referrals, we must engage a community clinician who is willing to come and evaluate the child and make that referral. This was difficult even before the pandemic, but unfortunately has become virtually impossible since the pandemic. Community clinicians are stretched so thin that many of them simply don't have the capacity to come in and add this task to their already burgeoning practices. In addition, DJJ no longer has contracts for the Max Plus level of RBWO care, which is one of the ways that we were able to manage higher needs youth that we knew needed PRTF, but to whom we could not, or for whom we could not get an admission. We did have a single remaining contract, but early in the pandemic, it was canceled by the vendor because of staffing and financial considerations. So we no longer have access to that level of care either. So as again, DCK Wood made allusion to, many young people that we know would benefit from and qualify for PRTF or Max RBWO go to YDC instead because they must access a level of service. So the whole intent of juvenile justice reform of not pushing children more deeply into the system for services that they could receive elsewhere, unfortunately, is not being met at that level. And youth who require treatment for dual diagnosis of whatever reason, serious mental health needs, in addition to substance use, developmental disorders, sexually problematic behaviors, any child with multiple needs is even less likely to be able to access community or residential treatment services, and even more likely to be pushed more deeply into the DJJ system for service access. Next slide, please. So in addition to that, and I started talking about this a moment ago, the referral to crisis services seems to be organized around utilization of the care coordinators through the youth's insurance, usually Medicaid provider. So again, a financial piece of the system is a crucial entry point to accessing clinical care. And DJJ is not included in that structure because we are not a Medicaid vendor and we don't have those relationships. They literally have not designed their system to be able to speak to us. So they're organized to speak with a parent or a care provider, but we're not recognized as a care provider, unfortunately. They, view that as a hospital, crisis stabilization unit, that sort of facility. So the rare times that we've tried to access and utilize a CMO Medicaid care coordinator, it's taken a lot of time and effort and calling very highly placed people just to identify who that person would be and to help that individual understand that we are someone with whom they can speak. And I mentioned earlier that the Medicaid providers also can't access services that their vendors can just tell them no, even though this is supposed to be the safety net for our children. And then, as I started to mention on the previous slide, the referral portal to PRTF is designed around payer source. There has been a small work group trying to figure out why DJJ couldn't refer. And this is what we've learned. If you aren't actively trying to access some sort of reimbursement, you cannot register for this site, which has been thus far an insurmountable barrier for us in access and registration to that site. So next slide, please. So for our residential placements, there are many challenges, and I actually will ask DC Kaywood to speak to some of these.
Sure. I think we had heard with the commission yesterday about the concerns of the number of bed capacity and the number of vendors and that being related to payment. And with there being so few beds, the kids that have justice involvement, specifically any type of gang involvement, or it appeared to be almost automatically denied. And many of our community vendors have indicated that the reimbursement rates for our youth are not sufficient. And we have been working within our own budget of trying to do some additional compensation around the hard to place kids, but that's not solved all of the problems we have around getting kids in the appropriate bed. And we just see that our kids are ejected from placement at a higher rate too. And often for behaviors that are typical of teens, such as talking back, or behaviors that are the reason that they're placed there, and even getting additional charges for those type behaviors, which then just pushes them deeper into our system. So next slide.
Thank you, DC Kaywood. We've spoken a lot about youth with high mental health needs, and I'd like to really highlight the fact that we have a growing number of youth with developmental disabilities who are being admitted to our system as well. Many years ago when I first joined the agency, there were very few of these young people, and it was very clear that courts and local jurisdictions, school systems, etc., worked very hard to find alternative services for such kids so that they didn't touch or touched only very lightly the juvenile justice system. Unfortunately, as the number of young people with developmental disabilities are growing in the community, we all know that the number of youth on the autism spectrum, for instance, is growing in the general community at large. And as developmental disability resources are challenging to access, more and more of these young people with autism and cognitive disabilities are coming more deeply into the DJJ system. I'd like to give you a couple of examples of this. We have young people with IQs at this moment. We have IQs, young people with IQs as low as 44. We have actually had a young person with an IQ of 42 for a sustained period of time as well. These are just children who are in our care right now. We have one 13-year-old young man with an IQ of 47 who's brain damaged as a result of his mother's efforts to drown him when he was a toddler. This young man has the cognitive understanding of approximately a 6 or 7-year-old. When he was admitted to the facility, he asked whether or not there would be playtime and whether the other boys would be nice to him and would play with him. Another young man is 12 years old with an IQ of 46, and he also has a speech impediment. He has very limited understanding of where he is very confused a significant amount of the time, and asks daily when he's going to be allowed to go home. He just doesn't understand where he is or why. Next slide, please. So accessing services for these kids is extremely challenging. And while they're with us, providing DD-specific services is also extremely challenging because many interventions for developmentally disabled youth are environmental rather than child specific, i.e. that's a way of managing the environment and structuring it in a way that is maximally supportive for the young person and meets the child's needs. For instance, a young person who is on the autism spectrum may have challenges with loud noises and with people being too close to them. Well, unfortunately, a secure facility is very loud and echoey most of the time, and it's a congregate care setting. So it's extremely difficult, sometimes even impossible, to structure the setting in such a way that that young person's needs are optimally met. In addition, kids with cognitive disabilities and who are on the autism spectrum can have a difficult time interacting with their peers. So sometimes they are bullied by their peers, sometimes they're scapegoated by their peers. You know, sometimes our young people will really rise to the occasion and will support and champion their peers with these limitations, but unfortunately that can't be relied upon. And we know that developmental disability resources in the community are critically short. They're just short everywhere. So unfortunately, that has led to more kids with DD needs being sent to secure facilities in an effort to secure safety for the young person. But as we just discussed, modifying the environment in such a way to maximally meet that child's needs is extremely difficult, sometimes impossible. Next slide, please. So changing tack just a little bit, DC Kaywood did mention that staffing, recruitment, and retention have been extremely challenging, and there are some items in our recommendations to hopefully help address that. As she mentioned, during the recession of 2007 to 2009, many behavioral health resources, including positions, were eliminated from secure facilities due to the austerity measures that were necessary in that time. Unfortunately, none of those positions were restored. So secure facilities are actually operating with fewer clinical staff now than they were operating with 15 years ago. And this is after the mandates of the 2013 reform legislation were passed that were increased the rigor of the interventions that we are required to provide. So we are very literally doing more with less for higher needs youth. As with everyone else in the behavioral health system, we struggle to recruit, and when we are able to recruit, we struggle to retain. Our vacancy rate for over a year now has fluctuated between 30 and 40% consistently. It has not risen above a 30% vacancy rate. And because the marketplace has become so competitive, we very frequently lose our most seasoned clinicians and our clinicians who obtain licensure for positions with our community partners, federal partners, etc., for salaries that are significantly higher than those that we can offer or compete with. So this, next slide, please. This is the end of our explanatory material. Here's some background information that we wanted you to take a look at. Are there any questions that DC Kaywood and I can answer for the group?
I just wanted to echo the concerns about children with developmental disabilities and autism across the board. And we just have not done a very good job in Georgia at all. And in fact, just the provision of services to any degree was completely an afterthought, and only after intense pressure from the community was that even considered. So we need to do a better job of changing processes as they exist.
Dr. Lukowitz. This is,
Yeah.
and I'm sorry, my camera is not working, but I have a couple of questions.
Please.
The first was, thank you. I thought that was an excellent presentation and was very informative. The DJJ clinicians, that's interesting. I really have not thought about it before, that they could not refer to the PRTF. So that's interesting. And I'm going to kind of follow up with that informally. Your salary increase for clinicians, are your clinicians in your facilities that you're wanting salary increases for, those are licensed clinicians?
Some of them are, Miss Skinner, and some of them are not. We used to have a higher percentage of licensed clinicians, but as I said, they can get such a significant increase that I simply can't match, that we are losing them as they get their licensure at rates we didn't in the past. We were able to retain them more so in the past. Now, they are all operating under the supervision of psychologists if they are not licensed.
And Dr. Doyle, is it not correct that they have to be license eligible? Is that correct?
That is correct.
My next one was, I think one of the things that's also a misunderstanding, having served DJJ clients at Devereaux, is that you could add to your list is that all DJJ kids are not aggressive. And I think just because they're DJJ kids, that some people believe that they are, or some providers believe that they are aggressive. So I think that's another misunderstanding. I think the other thing that causes providers to be hesitant to take them sometimes is because those that are aggressive require one-to-one supervision for a period of time until they stabilize, and some, when they are approved to come to provider, that additional funding is not always provided. And then, let's see, have you done any international recruitment to fill any of the vacancies that you have at DJJ?
Not in a structured way at this time. We've been working with our human resources department, and we're able to onboard a part-time recruiter specifically dedicated to recruiting behavioral health staff. So she has just started, and we are getting her trained, and we are hopeful that she may be able to help us expand our searches.
Are you there?
Okay, all right. Well, those were my comments. Thank you again. It was a very good presentation.
Are you there?
Yes, I agree. A very good presentation. I do have a couple of questions. I'm sorry, but I'm just not following the rationale why you cannot be a referral source. Is that in your chart in the spreadsheet? You indicate that that's an administrative decision. It's not in statute. It's not, it has something to do with credentials. What's the rationale for that?
So it is administrative, Dr. McGibbon. There is a referral portal that needs to be accessed in order to make a PRTF referral. All the referrals must go through the portal. But in order to register, you must have two things. You must have a federal ID number of some sort that corresponds with providing Medicaid services, which my clinicians don't have because we don't bill Medicaid. And then the other portion of the portal is a registration basically that connects to what sort of billing source or payer source are you attempting to access for the child's placement, which again, we're not attempting to access that. And our children, once they are placed through our auspices, usually do qualify for the AmeriGroup 180 Medicaid, but that Medicaid isn't active while they're in a secure facility and can't be initiated until they're placed. So again, because my staff aren't providers and aren't attempting to bill, the way the portal is structured means that they can't register because they don't have the necessary IDs and mechanisms to complete that registration. And we have a hard time we're caught in a bit of a catch-22 when it comes to the Medicaid, because it can't start until they're placed, but then the kids can't be placed until it starts sometimes for financial reasons. So that's been something we've been working very closely with the Mayor Group, trying to figure out how to navigate. DCK, will give me.
Yeah, I was just going to add that I'm not real clear if the structural changes is Georgia's system or in some way it's tied to the Medicaid or federal system. We have not been able to get clarity on who structured that system and who has the authority to make modifications to the system.
So one of the recommendations would be at that point, try to find out who can ask those questions and make that inquiry.
Correct. And yes.
Because it looks like there's several directions that can go that would require somebody to bring all those into one direction to try to get some response to what exactly do you need to do, or what does the state need to do, or what do we need to ask Medicaid to do?
Exactly.
I think you're right, Dr. McGivney, and it's interesting. And when I say we, I mean DJJ, Amerigroup, DCH, all of the stakeholders that have been working to try and figure out how to overcome this. We didn't even realize that structure was a barrier until we thought we had reached an agreement that was going to allow DJJ clinicians to refer. And then when our chief of psychiatry went to the portals to attempt to register, he was able to come back and say, this is the way it's structured. These were the barriers. And we were able to go back to our partners and ask some more targeted questions that brought clarity to everybody. Nobody in the conversation everybody seemed to realize that was how it was structured, but nobody had made the connections that would be a barrier to us accessing that. So I think,
I'm sorry, go ahead.
I was going to say, I think they're engaged people trying to overcome it. But some of the questions, like you said, we're not sure who to ask or where to direct them.
Now, the letter that you referenced in 2021 from Medicaid and Medicare, that's not related to this issue of referral.
No, sir. No, that's related to the question of whether Medicaid can be expanded for young people in DJJ involvement up to age 21, similarly to the Medicaid that's available to DFACS children.
Once they're released from DJJ.
While they may not be in a DJJ secure facility, but many of them have DJJ supervision and support for a significant period of time after they're released from a secure facility. But their Medicaid, their 360, not 180, their 360 Medicaid doesn't follow them after they're out of a residential placement. So particularly for a young person who turns 18 while they're in a DJJ secure facility, as it stands right now, when they leave, they have to apply through the adult system and all of the ins and outs. And of course, we all know adult Medicaid requirements are different than child Medicaid requirements. So, and that CMS letter gives the state discretion to expand our state child Medicaid to cover those kids. And that's the basis of our ask.
Thank you.
Dr. McGivney, let me add to, in reference to the PRTF discussion, that we did upline that all the way up to the commissioner of DCH, and our commissioner was involved, and she was attempting to help us with this. And actually, the young lady that we were trying to access services for, her order with us expired, and then she ended up in jail. And so we have not had the opportunity to get back with DCH to see if they could help us figure out exactly what needs to happen with that. So that really could be an internal conversation between our two agencies to explore that. But I think perhaps that DCH is going to need support in the way that some way or another that this was structured before, that there may be some additional challenges about restructuring it.
Thank you. That helps.
I think an arm wrestling match between Commissioner Oliver and the commissioner from DCH, that should be the way to solve the problem.
Sure. Mhm.
Well, thank you very much. This was very, very interesting and eye-opening, and I was aware about some of the effects of juvenile justice reform, but this was, I didn't know about all these hurdles to legitimate, worthwhile, and needed care. So hopefully that's something that we can pass on to the commission. All right, our next provider will be Melissa Haberlin DeWolf, talking about data sharing to improve behavioral health outcomes for youth in foster care.
Good afternoon, and I'm going to ask that my colleague Leslie Kelly shares her screen for Dr. Constantino and myself. So just to introduce myself briefly before we get started, again, I'm Melissa Haberlin DeWolf. I'm the Research and Policy Director at Voices for Georgia's Children. And we have been doing some interesting research over the last half year where we've been looking in detail in some of the examples to facilitate data sharing to improve care coordination for children in foster care, and are happy to share that with you all today. And then I'll let Dr. Constantino introduce himself or reintroduce himself and get us started.
You're not in presentation mode right now. I don't think it was meant to look this way.
Yeah, Leslie, we're still in a split screen, I think.
Yeah.
While you're doing that, I'll just introduce myself. I'm John Constantino. Everyone, thank you for having us here. And I am the new system chief for behavioral and mental health at Children's Healthcare of Atlanta. And I had an opportunity to present to this subcommittee in relation to autism. And so I'm very excited to return under another auspice today, and very glad to be working with Melissa on this particular dimension of behavioral health for children.
I am so sorry. I had two monitors up, and I'm not sure how to get this split screen.
Leslie, do you want me to just share screen and try from my device?
You know, let me try one more time, and then sure, certainly you can.
Okay.
So share screen, PowerPoint slideshow, share. Is it working now?
That's
Yeah.
better.
Okay. My apologies.
Thanks. And I think you could go on to the next slide, Leslie.
Okay.
Great. So from the standpoint of Children's Healthcare of Atlanta, I wanted to first highlight a kind of a cohort of children who represent sort of frequent utilizers of our emergency services. Children's Healthcare of Atlanta sees about 4,000 children a year in our emergency departments for a primary presentation for a behavioral health concern. And if you sample kids who are frequent users of that service, this was just a random sampling of 68 who had visited the emergency department 4 or more times per year for these kind of presentations. And you can see the statistics about these kids and how it relates to both foster care, social service involvement, and really traumatic life events. So about 50% of the kids returned within 7 days, 88% discharged to a psychiatric facility at least once, long length of stays, most had suicidal ideation, and 2/3 had actually been in custody at DFACS. Trauma often at the core of the behavioral health conditions of these frequent utilizers of emergency crisis services within our system. And trauma includes physical or sexual abuse, violence, neglect, and issues related to experiences that relate to juvenile justice system involvement. Next slide, Leslie. And then you'll want to click through these in a minute. So one of the things that we wanted to talk about today was the importance of information. And Melissa is going to share some information from a system level, and then I'm going to try to present some information briefly about how that actually relates and the power of having that information when it comes down to harnessing it for individual services and even at the level of families. So typically, as you know, a child is placed with a foster family or a kinship caregiver, and that in an emergency situation or a crisis situation, they'll present to an emergency department. The provider will seek medical history from the foster family, from the caseworker, from the CMO. Care is provided based on what information is available, and then a record is created on that encounter. The child is released into the community, and there isn't necessarily a circling of the wagons of, is this really the complete complement of information for this child? About a quarter of youth in DFACS custody are in care for over a year, up to 2 years. And of these, a third had 3 or more placements. And Melissa, we didn't include on this slide, but one of the other issues about children in foster care is that their case managers often rotate much faster than the period of time in which the kids are in care. So another instability and knowledge about those children relates to the sort of frequent turnover of care coordinators for these children. Next slide. And Melissa, you want to take it from there?
Sure. So I wanted to start just again by giving a little bit of a plug for data sharing. So just before I dive into some of the ways in which we can currently share data in the state, I just wanted to, remind folks that HIPAA does allow covered entities to use and disclose PHI without individual consent for a variety of activities, and that includes treatment of an individual. That said, we know that Georgia is one of the states with stricter confidentiality laws when it comes to mental health treatment. And therein lies, the main reason why behavioral health providers are often shy when it comes to sharing this information. But I do want to just emphasize that data sharing is possible, and that when in doubt, folks can always get consent. And DBHDD has put out policies and provided templates to use to participate in these sort of data sharing activities, like participating in Georgia HIN. So just wanted to briefly start with that. But our current landscape really put it in 3 buckets, 3 different tools really for healthcare providers to use. First, there are the private EHR software options. A good example of that, of course, is Epic's Care Everywhere or Share Everywhere. And that is one way that providers tend to enjoy sharing medical data, because you have that robust EMR data contained within. The sharing happens very quickly, and the systems are able to speak to each other. Next, there's GAMIS, which you guys are certainly very familiar with, which is specifically for Medicaid patients and providers. There's not a lot of functionality for patients. It's mainly with enrollment or prior authorization. And for providers, they can at least access claims data or payment data and member eligibility and prior authorization functions. And then, of course, there's the Georgia HIN, which is optional to participate in, optional EMR data sharing, but there is required data sharing for Medicaid, for the care management organizations, as well as fee-for-service. And in our interviews with healthcare providers throughout the state, we really heard that, providing, again, data sharing through the EHR software is really useful for them. But a lot of the road bumps would include having to make those ad hoc data requests to share and receive the data, different software not being able to talk to each other or merge, and then certain providers that are not able to share electronically at all. And in terms of GAMIS in the Georgia HIN, some of the limitations are, no medical data interfaces for patients, and then a lack of participation with behavioral health providers with the EMR portion, inconsistencies with the EMR data that are provided and available, no real deadlines for providers to provide EMR data by. Claims data lags, and the claims data lag is also present with GAMIS, which is even a little less interactive, view only, and the lag is typically around 6 months. One thing I did want to make mention, though, however, is that there is a new vendor for Georgia HIN, and they are working to improve the system's interface and usability. So, I think back to the main point there is also none of these systems interact with DFACS data. So one example that we looked at here was the health passport system in Texas. It was actually created many years ago in 2008. And it was created in collaboration with the state under their contract with their foster care managed care entity. Managed care organization, Superior Health. It's not a full medical record. It has information on diagnoses, though, gaps in cares, doctors and dental visits, hospital stays, prescription and shot records, and it's really driven by claims data. So the real goal of this data sharing initiative was to improve care coordination for children in foster care in Texas, and in particular to reduce the number of duplications of services for those youth. The system has a fact sheet that's an easy to read summary that includes member demographics, care gaps, EPSDT visits, allergies, and that sort of thing. There's also a contact sheet that has the child's PCP, medical consenter information, caseworker information, service coordinator, all right in one place that's easy to access. Again, I mentioned allergies is on there too, and there is a sort of smart function that the technology has where it looks at claims and allergies, and then notifies the providers of potential interactions with those drugs. Doctors can also upload care assessments. So behavioral health providers who are conducting those initial assessments can upload them to the charts. And then they also have growth charts, immunization labs, and basically a summary of medications filled, upcoming appointments, and things of that nature. So it's pretty comprehensive. The other good thing about this system is that they have created different logins for different folks who are working to care for the child. And of course, sort of different levels of data are included depending on the type of login that the person has. And so in this way, folks are able to really provide better care for the child that is with them. We can go to the next slide. So some of the key learnings from this health passport, or how it has been able to function well. First of all, the vendor has a steering committee that they run with the state. They have periodic meetings. They get feedback from stakeholders and work to consistently update the tool based off of that feedback. They also have quarterly meetings with the state in terms of reporting on outcomes and making modifications and things like that. One thing that was particularly interesting was that Health Passport was a part of a multifaceted intervention that was found to reduce prescriptions for antipsychotics in the foster care population, which is something that a lot of states are striving for. Next slide. So again, the pros and cons, the pros being because it's fully claims database, it has behavioral health provider claims in there. The con being that it's claims data, which is not as user friendly. It also does have a little bit of lag, though it's updated daily, but things like immunizations can sometimes have up to a month's lag in there. And then, of course, while they update the claims information daily, the claims are only plugged in as soon as a provider files them. So a provider has, a certain time frame within which to file the claims. So it's not able to show up real time when it's happening, but rather when the claim is filed. So there can be a lag in that way. There is obviously no medical data beyond the child's data that CMO has. So, for instance, you wouldn't have medical data from a child who is then back with their parents and then comes back into the foster care system. And then, of course, it doesn't have any child welfare data. Next slide. When we spoke with folks in Texas about Health Passport, a lot of providers were really excited about something that was happening in Ohio, actually. So we decided that we would talk to some folks from Cincinnati Children's Hospital who actually created a system called the Identity System, which is really a bi-directional data sharing system that merges child welfare data with EHR data from participating provider organizations, matches it in a cloud, creates one record for a child, and pulls it into a web portal that's then accessible by caseworkers and participating healthcare providers. And go to the next slide. They have already done a couple of studies. So Ohio's system is rather new. I believe it was started in 2017, but they have done some studies right now that have just been published about the outcomes. One of the key findings was that it did help caseworkers in their attempts to secure consent for medical treatment, to update new foster parents with the health information of the child that they're caring for, and also to hold those caregivers accountable for meeting their medical needs. And then from healthcare providers' perspective, they were able to quickly get the information that they needed about the history of the child and what they had experienced prior to their coming into the foster care system. Anything related to placement information and movement in placements while the child was in custody. And also one thing that they mentioned was that oftentimes children would show up to the ED and they don't even know that the child is in foster care. And so this helped with immediate identification of a child being in foster care. Next slide. So, the pros of this system are basically that it has the more robust EMR data included, as opposed to the claims data. The con to that is that similar to Georgia HIN, that EMR data is only as good as the participating providers. And so similar to HIN, you have to work to get participation from a robust number of health systems and providers to really make it work. Obviously, the major pro is the bridge of the child welfare data and the safe matching of that PHI together. And then, the Children's Hospital actually sold this technology to an organization that now works, and they are currently in consultation with about 25 states who are looking into utilizing this system. It's going to be adopted in 4 additional states outside of Ohio. And because they are now the ones who are working to implement this technology for states, they can really kind of hit the pavement and try and get participation from providers. And also are sort of early enough in the stages of development of the tool that they are really working with states to kind of develop versions that work best for those states. One other thing to mention too is that while currently the system is only viewable by healthcare providers and case managers, they are currently testing different functionality for logins for a variety of different stakeholders, similar to the ones that you saw with access to the health passports. Next slide.
So following on Melissa's discussions about these opportunities to engage this kind of data, I wanted to give a couple of examples of the power of this kind of data cross-referencing across the enterprise of children's mental health. And I want to preface these comments by saying that child welfare data is particularly important in any attempt to monitor and deliver mental health services to children for a couple of reasons. One is that placement in protective custody or foster care is an outcome unto itself. This is something that we all really want to avoid, in a sense, in terms of the efforts to stabilize and support families and so forth. But the other side of child welfare data is that, as everyone knows, child maltreatment, defined by child abuse or child neglect or sexual abuse, when you put those life adverse experiences together, the sum total is that they affect 1 in every 8 children in the population. And from a causal standpoint, the research has been done in many ways to demonstrate that these adverse life events that are encompassed by child maltreatment account for at least 1/4 of all of the cause of the mental health burden of children and adults in a community. They are very influential causes of behavioral health impairments. And so child welfare data, to me, is one of the most important kinds of information to weave into any kind of mental health strategy for a population. And I'll give 2 examples of how we use that in Missouri to advantage in terms of both the evaluation of the impact of mental health services, and then also what can be done to actually avert the course of occurrence of child abuse and neglect by actually incorporating other kinds of data that are readily available from medical records. So the first example is the Synchrony Project. The Synchrony Project is a project that I directed in St. Louis, Missouri, in which for the last 10 years, the St. Louis County Family Court referred all infants and toddlers who were placed in protective custody to the program to review and address any unmet mental health needs of the families in order to strengthen the likelihood that families could be safely reunified. And I'll show a slide about that in a second. And then Project Surround was an attempt to deliver the same kinds of interventions to families who were at risk for foster care placement or instance of child abuse based on epidemiologic data that was retrievable literally from the birth record in the electronic health record. And so I'll show those 2. Leslie, you can go to the next slide. So this is the data from the Synchrony Project. And in the Synchrony Project, 400 children under the age of 5 have been reunified with their parents following a first episode of placement in protective custody. And in this project, on the lower left-hand side of the screen, it describes the interventions that were used for these families of children who were placed in protective custody. And what the families received was parenting education using the Incredible Years curriculum, care coordination, parental psychiatric care whenever it was indicated on the basis of the parents' mental health needs, along with clinical appraisal of the pace of visitation during the course of placement in foster care, and medical recommendations to the court on safe reunification. That was what this project did, the value added to care as usual in the community. And this was conducted by teams of people who had expertise in child development, including child psychiatrists, nurse practitioners, and licensed professional social workers. And the data from the project is on the right-hand side in the table. And just to take a quick look at it, what we did was to compare really the re-referral outcomes of children who are reunified with their families, either in guardianship or reunification, based on national data from the Center for State Child Welfare Data, which is a database that includes over 250,000 children aged birth to 5. And then we also looked at Children's Bureau data from Missouri, which is, it's harder to compare with because we don't have the data in as fine a grain groupings by age and by guardianship versus reunification. But if you just look at the 1 to 2 year olds and the 3 to 5 year olds on the left-hand side for the national data, what you see is that when a child in foster care in those age ranges is returned to their family in guardianship with a relative or reunify with their birth parents, the rates of re-referral, what happens over the subsequent course, is that for guardianship, close to 20%, and for reunification, close to 30%, end up re-referred to the court. Another substantiated case of child abuse or neglect occurs, and they re-enter court. We looked not only in the municipality where the kids came from, which was St. Louis County, but all over Missouri, and followed our kids up over the course of the entire 10 years of this program. And what you see on the right there are the rates for this group of kids who receive this kind of supplemental mental health care, showing that it lowered the guardianship case re-referral rate to 3.4% and the reunification rate recidivism to 7%. And so this was a way, using this kind of information. Some of this information came from court data, some from child welfare data, but the point is that this kind of information is very powerful in letting you know that an intervention such as the ones that we put on the table here could have this kind of effect in offsetting risk for one of the most potent environmental causes of mental health conditions of youth. Next slide. And so one of the things that we did when we had seen some of this data, this is the actual, the 10-year data is in revised resubmission at the Journal of Pediatrics. We hope to publish that soon. But we saw the handwriting on the wall, how this was going for these children. And so we took another tack with a group of kids who were born in a high-risk urban obstetrical setting, knowing that from their birth records, there were ways that we could estimate likelihood and identify children who were almost at equivalent risk for referral into the system as kids who were already had a single initial placement into foster care. So on the x-axis of this slide is the number of birth records risk factors. So every baby has a birth record, and the birth records capture information on marital status, insurance type, the number of siblings, mom's education, whether or not prenatal care was received, whether there were prior abortions for that mom in her past, a medical history, mom's age, and the baby's birth weight. And among those, there are risk versions of those variables and non-risk versions of those variables. And if a child reaches on day of life 1, 5 of those risk factors on the risk side, then they epidemiologically are known through several studies now nationally that the likelihood is 40% that they will have an official reported or substantiated case of child maltreatment across child abuse or child neglect or sexual abuse. 6 of those risk factors puts them at 60% likelihood for that to happen. So day of life 1, babies can be ascertained for their risk for these kinds of life events happening. And so we approached their parents and asked, are the parents who are at these elevated levels of risk because of these family factors, would they be willing to receive and would they pursue an intervention that is known to offset liability for child abuse and neglect? In this case, for very young children, home visitation, either through nurse or paraprofessional home visitation, which is available by statute for all high-risk families in Missouri. And what this data showed was that families at extremely high risk, even in these higher echelons, were very likely to accept the referral, pursue the referral, and without uttering the word risk for child maltreatment, but just approaching the families knowing that they had these accumulation of risk factors, that they would accept on the front end the kind of interventions that would support them and offset these kinds of risks. So again, another example of how utilizing this kind of data and linking this kind of data can be extremely important. And as Melissa described, when a governmental payer is involved in any kind of service, it's always fair game to link that data through HIPAA to other kinds of government records for which we really have access. It's just a matter of harnessing and putting it all together. Leslie, next slide. I'll let Melissa wrap up with recommendations.
Sure. So our brief recommendations based off of what we chatted to you all today about are first, we would like to see DCH, including a requirement for portable health record technology in the upcoming Medicaid foster care CMO RFP contract. Second, and sort of at the same time, we would really like for the Office of Healthcare Strategy, Innovation and Coordination, DCH, DFACS. Also, this is critically important with input from the medical community to work to create a system that joins that more robust medical data, similar to the identity system, and child welfare data for multiple users across the system. Third, and this is sort of regarding the HIPAA concerns that behavioral health providers feel in particular, but all medical health providers, is for the state agencies to regularly and broadly disseminate data sharing guidance for those providers and their attorneys, so that they understand not just the limitations, but the possibilities around data sharing. Next slide. Last, per Dr. Constantino's slides, we would like for the state, DPH in particular, where a number of home visiting programs sit, to leverage existing data to drive access to and participation in those programs, as well as corresponding social supports for those families. We'd also like for DCH and the CMOs to ensure that they're facilitating reimbursement for all service components of 2-generational maltreatment prevention initiatives. And you saw the list of what some of those components can be in Dr. Constantino's slide. And then last, to create and fund an interagency home visiting commission that would be overseen by DPH to develop a comprehensive statewide strategy to increase access to home visiting. As I mentioned, home visiting occurs and is tied to a number of different state agencies and programs. And it's really critical that the state gets a good understanding of all of the different places that are driving it, ways in which it's happening, versions thereof, and develops a strategic plan to increase access to home visiting throughout the state. Thank you.
Eric, I think you're muted.
This was wonderful. And I think it sort of piggybacked on some of the information I saw yesterday at the full commission meeting. And one of the points that I made was that there's an agency called the Georgia Data Analytics Center. And their bylaw specifically prohibits the sharing of information related to mental health and substance abuse, which results from what I assume is an overzealous interpretation of HIPAA. And that's in direct conflict to the recommendations and interpretations of both the American Academy of Pediatrics and the American Academy of Pediatrics and the American Academy of Child and Adolescent Psychiatry. We need to have data to drive decision making and to move us forward. And that's why this is so important.
I do have a question. Melissa, when you looked at the Texas and Ohio, was the data sharing the result of MOUs or state legislation? How did they get to that point of having the data sharing passport?
In Texas, it actually started out with the RFP and the contract with the CMO. Then they did follow it up with some legislation. Actually, Dr. L, your point being that they followed it up with some legislation to make providers feel even more comfortable with the data sharing that would occur through the passport. But it doesn't necessarily have to have legislation. And then in Ohio, they did not have legislation. It was sort of a homegrown effort from the hospital system. And that hospital, I believe, does the majority of the initial psychiatric assessments for the children in foster care in that state. And that's how that relationship was grown. And they had a data use agreement with the state for the data.
Just one more question. Would it provide or could it provide some cover for providers if it is in legislation that providers have to share information?
I would say absolutely. And there is Georgia legislation that refers to data sharing for mental health and substance use disorder treatment. And as I mentioned, there are some exceptions for when you don't have to get individual consent in order to share that data. And so I think that it would definitely be smart for folks to, have a look at that again and see if there's any way that either within the legislation or at least guidance from the relevant state agencies that they could help with providers with their interpretation of those laws.
Thank you.
Any other questions? Okay, well, let's go ahead and move on. Our next speaker is Darlene Lynch she's the head of external relations for the Center for Victims of Torture in Georgia.
Hello, everyone, and thank you for having me today. It's a pleasure to be here. Like the other speakers, I have presented a similar presentation to other subcommittees, but since that time, we've been doing some focus groups and some talking to others working in this area about the special needs of children in Georgia's refugee and immigrant communities. And so I'm looking forward to sharing that with you all. Before I start, I just want to say, as you said, I'm head of external relations for the Center for Victims of Torture, and I'll say a word about who we are, but also who I am. I am the mother of a adult child with mental illness, and I'm also a very long time CASA, court-appointed special advocate for DeKalb County. So I've worked with foster children for many years. I had a child who was in care for 5 years. Spent over a year at Devereaux, was at Lighthouse, was at Hillside, was at every possible location in Georgia, was in detention, was in CHOA. And I just want to, I appreciate what everyone's saying about this lack of communication and data sharing, because there were many times when the CASA, the volunteer, is the only consistent person in that child's life and that child's case. And there are many times when I would show up at the hospital or at a new facility before the caseworker would come and would be the person sharing that kind of information. And so I definitely see the need for that recommendation. And I also want to reflect a little bit on Dr. Constantino's comments about trauma and abuse, maltreatment of children. I've represented clients who are victims of torture, and I've worked with children who've been victims of violence. It's very similar experiences what these folks have gone through. There are some differences, but for a lot of people, torture is a very foreign and scary sounding thing. But keep in your mind that you've probably encountered children who have had these kinds of experiences, just not in a political context. With that, I will get started. What I'd like to cover today is a little bit about Georgia's changing population. This is a very rapid change. And what I want to convey is that we're a little bit behind the 8 ball on this change, and that there are things we can do to catch up. I want to reflect on Georgia's very special role in refugee resettlement. A lot of folks, longtime Georgians, aren't aware of it. Talk a little bit about the torture and trauma that we see among refugee and immigrant children in Georgia, and then give you some solutions from these focus groups and from other discussions and from CBT's own work. So the Center for Victims of Torture is the world's oldest and largest torture survivor rehabilitation program in the world. There are no other ones like us, in part because we do a variety of things. We do comprehensive mental health care, training, research, and advocacy. And that's where I fit in. I actually do a lot of policy work. CVT was founded 1985. We now have 400 staff around the world. In some of our locations, we see a lot of children, particularly in Ethiopia, because there are a lot of children in Eritrea, the neighboring country, who are forcibly conscripted into the military in very slave-like conditions and for an indefinite period of time. So we see a lot of children there. We see a lot of children in Jordan, Syrians and Iraqis. In Uganda, we see a lot of former child soldiers who were part of the Lord's Resistance Army. In Georgia and in Minnesota, where we have another large center, we tend to see children who were secondary survivors of torture, meaning they witnessed the torture of their parents, or they have been living with the impact of that in their families and in their lives. I will say CBT's model of care is a holistic model. It involves not only psychotherapy, but physiotherapy, intensive case management, and professional specially trained interpreters. And we have done our own randomized controlled trial, a 5-year trial that has produced really terrific results for this model of care, far better than regular standards of care for this particular population, and also reducing hospitalization and other costs. I'm happy to share that report at another date, another time. So the demographics. Georgia is a top 10 state for racial and ethnic diversity. And you can see here, the blue states are the ones that are most diverse. The lighter you are, the more diverse you are. Georgia has increased its foreign-born population by 90% in the last 2 decades, compared to 25% of the US-born population. The census that just came out in 2020 showed a tremendous increase, for instance, in the Asian population by like 50%, and in the Latino population by 30% in just the last 10 years. So Georgia is rapidly diversifying. Right now, 1 in 10 Georgians is foreign-born. So 1 in 10 Georgians is an immigrant. But it is important to note that though 1 in 10 Georgians is foreign-born, 1 in 7 Georgia workers is foreign-born, because we have an aging US-born population. So 14% of the workforce are refugees and immigrants. 20% of our doctors, and we've been talking about foreign-trained doctors and clinicians, 20% of doctors are foreign-born, 30% of our small businesses, and so forth. And during COVID pandemic, Georgia refugees and immigrants were largely on the front lines of our workforce. So it's important for these individuals to have equitable access to mental health care so that they could continue to contribute to our state, just like other Georgians. The other thing I want to lift up is how many folks in Georgia are English language learners. So it's hard to learn English. It's hard to learn a second language when you move to a new country. Nearly half of foreign-born Georgians are naturalized citizens or are in the process of becoming citizens, but many of them are still working on English. So we're talking about 500,000 Georgians have limited English proficiency. And you cannot do therapy with limited English proficiency. It is the language barrier prevents adequate mental health care. So we know that, it's 500,000 people, 5.4% of our population are not English proficient. But take a look at this deeper dive. If you go into Georgia's really diverse communities, and by that I'm talking about Gwinnett County or Clarkston, that's where CBT's Georgia Center is based, in Clarkston. Look at those numbers of how many people are not speaking English at home. Okay, that is the language that they are going to want to talk about their mental health issues in, or if they're in crisis, they are going to revert to. In Clarkston, and I encourage everyone to come to Clarkston. It is a wonderful, special place. It is the most diverse square mile in America. There are 40 different nationalities and 60 different languages in Clarkston. And 40% of the folks are not speaking English. If you look at children, you'll see something similar. 100,000, more than 100,000 Georgia children are in ESOL classes. All right, and many of them, nearly half, are not English or Spanish speakers. They're speaking a whole variety of different languages. So at CBT's center in Clarkston, we are seeing a lot of folks who speak Pashto or Dari from Afghanistan. That's a hard thing to find an interpreter for. We have a lot of Arabic translators and Spanish and Burmese and Swahili. As an aside, I was listening to Representative Oliver's comments about relaxing or streamlining licensing for foreign trained clinicians. We have a clinician at CBT who is working as a translator, but she was a psychologist, a PhD psychologist for more than 20 years in Syria. So she hasn't been able to re-enter her practice. We could use a Syrian clinician, and she's working instead as a translator in our office in Clarkston. So the children are also speaking a variety of languages in Georgia. One of the reasons Georgia is as diverse as it is that it plays a very special role in the refugee program, in welcoming refugees. Right now, and you probably have heard this on the news, we are at historic levels of humanitarian crises in the world. 100 million people are displaced. That number jumped dramatically since the crises in Afghanistan and Ukraine. Including among these numbers are a lot of children, 27 million refugees, and about half of those are children. It's important to know that a very, very small fraction of these people are ever resettled, less than 0.25%. And then less than 0.1% of those are resettled in the United States. And then less than those come to Georgia. It is a very long and rigorous vetting process involving multiple US agencies, multiple security checks, health checks, and so forth. And it is really what they call a careful selection by governments of individual refugees to come live in their country. So right now we are experiencing a high level of displacement and large number of refugees, not just from Afghanistan and Ukraine, but from Syria, from Venezuela, from Burma, Democratic Republic of Congo. So Georgia is a top 10 state for refugee resettlement, always has been. Georgia has been resettling refugees for more than 4 decades. back when the Vietnam War was happening. And, people say, why Georgia? People outside of Georgia sometimes hear some anti-immigrant rhetoric flying around. You know why Georgia? Because Georgia has a strong faith tradition. It has a strong history of hospitality and welcoming the neighbor. And we rely on that in welcoming our refugees here in Georgia. And in fact, Georgia's resettlement program is a model for the nation, with about 90% of all incoming refugees economically self-sufficient within 6 months. Whether they speak English or not, they are supporting their families within 6 months, which as a parent of adult children astonishes me. But this program works, and we traditionally welcome up to 3,000 people a year from countries around the world. And this is what happened in the last year or so. We had crises in Afghanistan as well as in Ukraine, and Georgia opened its arms to these individuals. We very, very quickly took in almost 2,000 people from Afghanistan, and we are now taking in folks from Ukraine and have about 1,000 people from Ukraine, and that is on top of hundreds of people from other conflict zones. This has been particularly challenging because in the prior administration, the refugee program was shrunk. We lost a resettlement agency. We lost a lot of our capacity. And so we're really building up at the same time we're welcoming historic numbers of people into Georgia. I will point out that, as I said, half of refugees are children. We have seen a lot of very large refugee families from Afghanistan in particular, which has caused some housing issues that we're not accustomed to, but also women and children from Ukraine have been coming, and children. We have been asked, for instance, to provide mental health services for children from Ukraine. Right now, CBT, like the other providers in Clarkston, has a wait list that's 3 to 6 months long. Most of the people on that wait list are from Afghanistan, including a 13-year-old boy from Afghanistan. Most of those folks are suffering not only from being hunted down, from the chaos of having to escape, but they have almost all of them left family behind, and often in very dramatic and horrific circumstances. So they are separated from their family, and all of these individuals, the Afghans and the Ukrainians, are in a legal limbo that just complicates things further. They only have parole, a humanitarian parole, and a right to stay in the country for 2 years, and then there's really no path. They would have to seek asylum, and asylum is very rarely granted. In Georgia in particular, it's less than 5%. So that legal limbo is also a big stressor and on their mental health. One of the reasons that Georgia's program is successful is it's a very long and public-private partnership. So you'll see here that DFACS is part of that partnership. And they work with the Department of Public Health, where we have the state refugee program and the state refugee health program. DFACS provides initial public assistance, Medicaid, food stamps, and so forth, refugee cash assistance. These are all limited forms of assistance that last months before refugees are on their feet again. And they work hand in hand with the 4 resettlement agencies, which are on the left, and a variety of health providers, which are on the right. There are only 2 mental health providers, CBT and Positive Growth, in the Clarkston community. There are some others that serve immigrants outside of the area, but we are the only ones in the Clarkston community. If you look at this public-private partnership, there's an agency that is missing, and that is the Department of Behavioral Health. The Department of Behavioral Health, I don't know if it's always been this way, is almost entirely disconnected from this. They are not aware of when refugees are coming. They are not aware of refugee mental health issues. For the most part, the refugee health programs will refer directly into the community so that the Department of Behavioral Health doesn't see those individuals. I was on a call with the head of the DeKalb CSB, which is located about 3 miles from Clarkston. They see almost no refugee clients, while we have 3 to 6 month waits. Refugees are legal here. They're lawful here, so they are eligible for safety net care, as are many of our other folks. They just are not using the CSBs like we would we would hope that they would. I do want to add that with respect to children, Georgia also has many unaccompanied youth, and these are kids who cross the border without their families. They're taken into custody, and then after a sponsor is identified and vetted, usually a family member, they're sent to that sponsor. So Georgia's also one of the top states for these children. As you can see, we have 5,000 children in 2020, the fiscal year 21 alone, 5,000 kids. So as you can imagine, the experience of migration, and particularly of being a refugee, involves a lot of different types of trauma. And so in our work, we call it the triple trauma paradigm. So, for a lot of folks, they're thinking about the trauma pre-flight in their home countries. Were they imprisoned? Were they arrested? Were they beaten? That's true. Most of our clients were targeted because they were protesting a corrupt government, fighting against business corruption. They were doctors who were trying to share information the government didn't want them to share. They were, for instance, a Venezuelan architect on protesting in the streets. And these folks are rounded up, imprisoned, and tortured. We've had Ukrainian and Russian individuals, actually lawyers also, as clients. And so they've experienced terrible things, and so have their children. It's often a common tactic of torturers to torture children in front of their parents, or torture parents in front of their children, because the goal of torture is to silence people, terrorize people. So there is a lot of torture and trauma pre-flight, but there's also very arduous journeys. We have people from Cameroon who crossed the border in Mexico. I had a client who was tortured in Iraq under Saddam Hussein, and his flight took him from Iraq to Turkey to Holland to Boston. And especially for women and children, they're very vulnerable during this migration, and subject to assaults and sexual assaults. And CBT does have clients who were sexually assaulted and impregnated during the journey. And then I would say the part that's overlooked is post-flight. And post-flight is adjusting to their new lives in the United States. And, we've had, there's somebody on our advisory council, Dr. Haval Kelly, who is a physician, a Syrian physician now. He's at Northside Hospital. He came here with his family as refugees. His father was a very successful lawyer and part of the Kurdish government. And when he came to Clarkston, they were living in kind of a small, cramped apartment. They had very little means. And, Dr. Kelly will tell you he was working in, washing dishes to support his family. That kind of change in your life is difficult. when your parents are ill or suffering and, you don't know you can't navigate the system. And then imagine that if you're a parent of small children and trying to figure out the school system when you don't speak the language, or how do you get your child health care? How do you parent a child? At CVT, we see a lot of this. What is allowed in the United States that might not be allowed in other countries, that might mean that your child is removed from you. There's that post-flight trauma is also quite real. So I talked a little bit about what we see at CVT, and our services are really reserved for the most severely traumatized, those who have endured torture or war trauma. Our research has shown that, and the US government also endorses, that 44% of US refugees are likely torture survivors. If you do the math, and Georgia's welcomed 40,000 refugees in the past so many years, there are a lot of people that may be suffering with the effects of having been tortured. And not all of them need our help. Some of them are extremely resilient, but some of them do need help. And the reason CVT is in the state of Georgia is because of those numbers. I will say too, sometimes folks, as I mentioned early on, think of torture in a very limited sense, but the definition of torture is just the deliberate infliction of severe pain or suffering on a person by someone acting under color of law. So very similar to child abuse or terrible forms of child abuse, except it's not being done by your family, it's being done by somebody acting as an authority figure. For most of our clients, the main conditions that we see as far as mental health are PTSD, anxiety, depression, and somatic pain, but also obviously a host of physical ailments and disruptions to their families. I'm not going to get into the mental health conditions. I'm not a clinician, but there is a lot of research out there. And I wanted to just highlight, maybe for later reviewing, some of the most recent research showing that, for instance, the Lancet published just this year, the difference between PTSD between refugees and non-refugees, US-born individuals. So we're talking 31% to 6%, depression 25 to 8, anxiety 14 to 3. These are huge differences, and probably align maybe with what Dr. Constantino was talking about for other kinds of ACEs or trauma. These numbers were even higher for young adults. And we are seeing, increased risk for children with refugee backgrounds, and particularly for children who are detained. A recent report showed that in 600 cases in 3 months' time of migrant children considering suicide or trying to kill themselves, being held in immigration detention without their parents or without full understanding, without any definite end in sight. That's very common. So, some solutions. I first want to highlight, again, my love for the city of Clarkston and for the community that we have. We have, and I'm sort of teeing up for the next presenter here, the Clarkston Community Center. We have an organization called the Coalition of Refugee Service Agencies. We have more than 24 organizations that are part of this coalition, all providing various supports to refugee and immigrants, including children. And especially children. And they don't all provide intensive counseling like CVT or positive growth, but they're providing other very much needed supports, prevention, and lower level types of mental health assistance. So I will say that is one of the positives that we have going for us. We have a community of providers that have stepped in to fill gaps that the state has not gotten to yet. So what are we seeing? And these were pulling from my discussions with folks in the community, the organizations you saw on the screen there, schools such as the Global Village Project, the International Community School, the public schools. They are receiving children who may have seen their parents killed and their friends raped. They are seeing children who do not know how to express this trauma, even in their own language, and who are then having to adapt to their new worlds and go to school here in the United States. We also see just an unfamiliarity and a discomfort with Western ideas of mental health. So, folks don't know what it is. We don't actually call CBT's center a mental health clinic. We call it a healing center. We don't have any identification on our building. It looks like a home. It's walking distance. So we talk about holistic health, whether it's spiritual, that might be part of the solution. We have different models of mental health care that we use. And we also have to educate on vocabulary and educate on somatic pain, so that when a child or when a parent feels that they have a heavy heart or pain in their heads, that they can understand that that might be because of their trauma. And when their child is acting out or is not able to focus, that might be because of their trauma. And that counseling can help. Even a Western style of counseling can help. Interpretation is always an issue, and CBT has individual interpreters, but a lot of folks don't. And so you're relying on children as interpreters from as young as 8, 9, 10 years old, or staff who might be their teacher one day and an interpreter in a mental health session another day, or individuals from the community. And it's a very tight community, so interpretation is an issue. Stigma, and I sort of mentioned a little bit about stigma, but again, in a tight community, you can be ostracized very quickly. And in some of our communities, mental health care is still viewed as a kind of possession or curse that could impair the rest of your family's ability to thrive. And so there can be a reluctance to have your child get mental health care for that reason. We also have, not just in the refugee community, but in the broader immigrant community, a real fear of immigration consequences. If authorities think that we're not doing well, will they kick us out? Will they take away my kids? CBT, for instance, in St. Cloud, Minnesota, has a parenting class to address this fear of, will they take my kids? What are the laws around parenting? And when I was in the DeKalb juvenile court, I did see kids removed from refugee parents who, a lot of it was cultural and very, very difficult. So I mentioned this, the DBHDD safety net programs are not serving these communities. There are very few APEX programs in DeKalb. There's hundreds of them statewide. There's only one in Clarkston. And when I spoke to the person who's been running that program since 2015, she rarely has refugee children in that program. Why? I think it's a complex mix of reasons. But in the past 7 years, they have not increased the engagement by the refugee families in that particular APEX program, where they are seeing the bulk of the children from the refugee community, and that's Freedom Middle School. I mentioned the DeKalb CSB sees virtually no refugees. They see some, and some are referred directly from the Board of Health after they're screened on admission. But they don't see them. And, it could be the 3 miles. You know, we like to say if it's not walkable, it's not workable, but it's also a big imposing building, very hard to navigate. Spanish access may be there, but all these other, myriad languages may not. So it's not serving this community. Insurance barriers, we've heard a lot about expanding Medicaid. Everybody wants to expand Medicaid. I will say that Georgia is an outlier in not expanding Medicaid for lawfully present immigrant children. So there are immigrant children who are lawful permanent residents, and they cannot access Medicaid or their families can't access Medicaid for 5 years. So, I mean, that's sort of most states, including our neighboring states, South Carolina, North Carolina, Kentucky, Florida, have gotten rid of that so that children don't fall through the cracks. But we have not done that. So behavioral health equity, this is something that I kind of trumpet in all of my different roles on the Georgia Mental Health Policy Partnership, as part of the advisory council, the planning and advisory council for Georgia mental health, behavioral health. What are we doing for behavioral health equity in Georgia? We're one of the most diverse states in the nation. What are we doing? SAMHSA, which provides large block grants, obviously, for our mental health program, expects its dollars to support equity in access, services, and outcomes. DBHDD recognizes the growing diversity in the state and the need to be more culturally competent, but it, year after year, leaves that section of the SAMHSA block grant blank. Now, it is not mandatory, so I get it. It's more work, but they do not respond to SAMHSA's questions about what are you doing for equity. This has left us really far behind the other top 10 diverse states. And I'm not going to lay it all on DBHDD. DBHDD has done amazing work in the past decade. They've got a million irons on the fire, but there's never been a mandate for them to do this. They started a work group and had a draft cultural competency plan more than a decade ago. And that plan has not advanced. Well, we know what's happened to Georgia's population in the meantime. So these are my last 2 slides, and I want to offer some solutions. Some of them I have shared with other committees as well, subcommittees as well. We need a division of cultural and linguistic competency or mental health equity or prevention of disparities, whatever you want to call it. Almost every state in the country has one of these. We do not. And, I think that that's part of the reason we haven't advanced. We have a work group here, and we have an interagency effort here, and we have one person who was really into it and then they left. It just hasn't happened. We do not identify culturally and linguistically diverse populations as a priority group. And that means we don't collect data on them. And, contrast that to the Office of Deaf Services. The Office of Deaf Services was created to provide culturally and linguistically appropriate care, meaning ASL, to Georgia's deaf population. This is a model for what we need to do for our foreign-born population. So when I go to these advisory council meetings, I hear the Office of Deaf Services report out on their indicators. These are how many people we have in the deaf community. These are how many people we serve. This is what the outcomes were. But we don't do that for these diverse communities. So as SAMHSA says, let's start collecting the data and looking at strategies. The national class standards, culturally and linguistically appropriate service standards, have been adopted by more than 30 states. They're a roadmap. We can use those. We have not adopted them. We talked about building a workforce that can meet the needs of our changing population. Streamlining licensing so that our translator when she asks us, can I join CBT? We can say, yes, please. And she does ask us all the time. She's willing to testify. And we really need to tap this untapped resource. They are bilingual, bicultural, and this is what we need. DBHDD offers cultural competence training, but it is not required. It's more of a one-off, and CBT has actually provided some of this training, but you can choose to take it or choose not to take it. So even if you are serving a community like Clarkston, there's no requirement that you have any cultural competency. I will point out that the CCBHs are required by federal law to not only train, but to be certified in cultural competency. And as the department rolls out more of these types of clinics, they're going to have to do this for these CCBHs. So there again is a model for what we can do to strengthen the workforce. Let's amend the state plan so that immigrant children can get care. I think that's a fairly straightforward solution to thousands of kids in Georgia. And it is a recommendation of the Georgia chapter of the American Academy of Pediatrics. And this is my last slide, and this is a thick one. Let's improve the utilization of DBHDD. It is the safety net for all Georgians, even new Georgians, even foreign-born Georgians. 1/10 of our population, right, is foreign-born, more than 1 million people. So I'd like to see DBHDD coordinate with the state refugee health program. I think we need an FTE that understands when are these folks coming in, what are their needs, how are we going to meet those needs, how is the state going to participate in this and ensure that these folks get on their feet and thrive and contribute. Pilot an APEX program for these kids with high rates of trauma, one that has outreach component and an interpretation component, a cultural competency component. Provide targeted funds so that the CSBs and APEX programs in these communities can really strengthen their competence as far as cultural and linguistic competence. When I spoke with the head of the DeKalb CSB, he was looking for separate funding to try to do additional work in this area because he recognizes that they're not doing much for their surrounding community and would like to, but they need funding to do it. So he's been looking at that. We have a lot of community members that we could train as paraprofessionals and peers who could really help with the interpretation and navigation of our system and are really needed to walk folks through. But that has to be reimbursable. And right now in the DBHDD manual and the CMOs, interpretation and navigation services are not reimbursable. So in fact, for CBT, where we have an actual person follow every client that is entirely privately funded, we can use language lines for small things, but we wouldn't use them for counseling. This is something I've been pushing for quite some time and worked with Dr. Bona many years ago on this proposal. We need a tier 3 category for the providers who are filling this gap, who know how to do this work, who are providing specialized care to refugee and immigrant trauma survivors. And Dr. Bona was saying, listen, they used to have a program right in the DeKalb CSB, a torture and trauma survivor program. And that was not sustainable because it was private money and it just didn't last more than, I think, 3 years. And when CBT came to Georgia about 6 years ago, he said, ask DBHDD to make you a specialty provider because we need you. But there has not been any flexibility in that. And I'm not just talking about CBT. There are other providers. Sur Familia has presented to this group. Positive Growth is a member of a work group that we work with. that are also filling this gap and providing culturally and linguistically appropriate care for a very challenging community and lawful community. And then finally, this is also a segue to the next presentation. You know, we have different levels of intensity for mental health care. Our community nonprofits are really filling that prevention and mental health first aid, mental health support function, preventing isolation through activities like soccer or hiking or whatever the case may be. And we need more of that in the community. Not everybody needs intensive care like the kind we provide at CBT or some of our partners. So I encourage the state to really maximize the tremendous resources we already have in the community to serve this population. And that's it for me.
Do we have any? Thank you, Darlene. This was very, very good. Very sort of eye-opening. I don't think I realized that refugees were completely excluded from being able to seek care here in Georgia. So, does anybody have any questions?
Well, thank you very much. Let me stop sharing so my.
Okay, so looks like we have our next presentation is also regarding similar population. Looks like Daviel, is it Lakin?
LaKind.
LaKind. I guessed wrong.
That's okay.
And Amber McCorkle. So Daviel, welcome, and go ahead, and the floor is yours.
Thanks. Amber, go ahead and share our slides if you want. I want to apologize preemptively. I'm having terrible internet connection problems. And so if I disappear, Amber will just take it away until I find my way back to you all. We're going to be talking today. So as Darlene mentioned, we are going to be talking about some work that we're doing to embed mental health supports for Georgia's refugee youth and families in everyday settings, in community-based organizations specifically. You can go ahead and advance, Amber. And I'll just introduce myself while Amber's making that move. So I am a clinical community psychologist, and I'm a licensed psychologist in Georgia, and a faculty member at Mercer University in their Department of Clinical Psychology. I focus on dissemination and implementation science and supporting paraprofessional or lay workforces. I do a lot of work around kind of 2-gen support, so supports for both kids and their families. Amber, is it being funky? Should I try to share it on my end? Okay.
Yeah, all of a sudden, yeah.
No problem. Give me just 1 second. All right. I will go ahead and share my screen. Our folks, let's see, here we go. All right. So by way of agenda, we'll quickly be introducing some ideas behind the work we're doing in the communities that we're working in, which Darlene already talked about a lot. And we'll also be covering some of the same information about the needs of refugee youth and families. We'll keep that brief since Darlene already did such a beautiful job covering that. And we'll talk a little bit more about opportunities for mental health promotion in community-based organizations and other community settings, and then walk through some work we're doing to pilot a stepped care model of family engagement and mental health promotion. So really broadly, I think Amber and I are both trying to think a lot about how we support the mental health and well-being of vulnerable youth, and thinking a lot about how we can do that by leveraging community-based workforces who can support families, enhance key settings such as community-based organizations, and empower communities.
So quickly, I'll introduce myself. My name is Amber McCorkle. I'm the Director of Education and Programs at the Clarkston Community Center. So I'm not going to go into detail over this. I feel like Darlene gave a pretty good landscape of what Clarkston looks like in the community that we serve. But one thing I want to highlight about the community that we serve is that the poverty level has risen. And when you factor in stressors to mental health, right? This is definitely one of the stressors. Right now, 56% of our children that reside in the zip code that Clarkston is in, which is 30021, are living below poverty level, which that's a pretty significant increase from about 2 to 3 years ago. It was at a third. So we're now over a half of our population living below poverty. Was I muted the entire time?
No, you're good.
Sorry. Thanks. So I like to paint a story, give you a story, paint a picture of what our youth look like that we serve. We already talked about their journey here to the United States. Just that significant trauma of coming from one country, the flight, possibly even having to reside at a military base, as we've seen with our Afghan community, and then their transition into a place to live in Clarkston, for example. Right now, we're already facing an affordability crisis. And what we typically see is that by age 8, a lot of our children have become interpreters for their household. Even if they don't speak the best English, if they speak even a little bit of English or can understand a little bit of English, they are the interpreters for their parents. So they're already shouldering some burden of an adult. By age 12, mentally, they're an adult, because by age 12, they're already helping their parents pay bills. They're helping most of their siblings with their schoolwork. We saw this a lot, especially during the pandemic when everyone was doing virtual learning. Our kids were at home in households, in multi-family units of maybe 2-bedroom apartments with 4 or 6 children, trying to help their siblings do work. That in itself is an additional stressor. And so at the end, as we see this little boy is screaming out loud because they're now shouldering all of this responsibility, yet when they go to school, they're still being treated as if they're a 12-year-old, but they're not a 12-year-old in their mind. Can you move to the next slide?
Mm-hmm. So I think, again, we already went over through Darlene's presentation a lot of the barriers to enrollment and sustained engagement in what we here think of as traditional mental health services. There are transportation barriers, barriers related to where services might be located and how many there might be in a community. There are really long wait lists. The format of psychotherapy might be strange or uncomfortable, and there's really tremendous stigma in these communities as well. And so all of these serve as pretty significant barriers to engagement in services. But when we zoom out a little bit and think about where mental health is supported, we so frequently focus on these mental health centers and clinics. But if we think about more of an ecological framework for where mental health is promoted, we understand that it can be supported across neighborhoods, homes, schools, sports teams, third spaces, really everywhere that kids are growing up and learning and playing and living their lives offer opportunities for mental health promotion. And so we're thinking a lot about after school programs, summer camps, and other out of school time settings. And these settings and the community-based workforces who work inside of these settings have numerous opportunities to enhance engagement in services. They can address these logistic barriers that we were discussing because these are settings that families already access. They're already going to, I mean, as we'll hear when we get to talking about the community center, they're going there all the time for all sorts of things. So that logistic barrier isn't there the same way. Perceptual barriers are addressed because coming into these community settings feels much less stigmatizing. It feels like you're connecting with folks who are like you and who understand you. The folks in those settings are likely familiar with the culture of your community. And they're well positioned to serve as community advocates and boundary spanners, which can address some of these systemic barriers that we are also facing. I'll hand it back over to Amber to talk about the Clarkson Community Center specifically.
So why is the Clarkson Community Center significant, or organizations like ours, community-based organizations? So we were founded in 1994 as a multicultural community center, nonprofit, located in Clarkson, which is in DeKalb County. We're a meeting place for a variety of different people, but specifically for long-term residents, right? And your traditional US citizens. So our mission is focused on community building and celebrating cultural diversity. We do this through 3 forms by promoting education, recreation, the arts, and then lastly, of course, what we're doing now is 4th would be advocacy work. So when we speak of these programs, specifically with youth, one program we offer is our summer camp, the STEAM Plus Summer Camp. So I want to put an emphasis on the plus. The STEAM portion, I think we all know this is centered around piquing interest in STEM, but the plus portion is where a lot of times summer programs fall off. Within our summer camp, we also offer financial literacy classes, college prep, but also we partner with Mercer University to offer small mental health support groups for our kids. In addition, in response to what we saw going on in our community with the pandemic, we created what we call the CCC Quiet Zones. It was one of the first formats of small learning pods within the community. So what we did, because we're in the community and we understand, what our community was going through, we knew, as I stated earlier, that many of our children were living in multifamily apartment units where they had access or little access or no access to internet. They didn't have the support they needed to get their academics accomplished. And they were probably just dealing with a lot of mental strain, of the pandemic. So we created the Quiet Zone to where they could physically come to the center. They were provided food, breakfast, lunch, and snacks. They were provided tutorial services, and they were provided mental breaks where we physically took them outside. They got a chance to get out of isolation and to receive that additional support that they may not have been able to receive within the 4 walls of their home, right? Also, we have our after school program, which offers homework assistance, tutorial services, as well as, once again, Mercer University having those mental health support groups there. Because we also know that if a child is not well mentally, they're not probably going to do well academically either. And we see the connection with that. And lastly, we have our Leaders of Tomorrow program, which is a leadership program for high school refugee youth that focuses on civic engagement and developing leadership skills. So additional programs to factor in, once again, the importance of the community-based organizations is that we know that there are chronic stressors to mental health, external factors, right? So for an example, we have a food pantry. If you don't have money, right, and you can't purchase food, I doubt that your family's mental health is going to be well, right? So we have our food pantry available. It's an emergency food pantry, as well as we have scheduled times on Saturdays where people can come get food. We also offer additional classes for adults and seniors, like our ESL classes, citizenship classes, computer literacy classes, because we also saw where during the pandemic, a lot of our kids were having to go online and help their parents learn how to pay their bills online. So the computer literacy classes are for our adults and seniors, a community garden, senior focused programs, and just additional programs that just betters your mental health, like dance, Tai Chi, and Tabala martial arts.
So all of that kind of paints the picture of how important the Clarkson Community Center is as just one exemplar of a community-based organization that's so deeply embedded in a community and so connected to a community and really familiar with the needs and the strengths and opportunities within different communities. So we're trying to leverage all of those strengths and all of those opportunities to pilot this project right now to enhance youth mental health promotion in community-based organizations like the Clarkson Community Center. And I'm just going to sketch out this project, and then I'm more than happy to answer any questions folks have, but I know that we're low on time. So at the moment, we are conducting a mixed methods needs assessment, as well as convening a community advisory board to inform the development of a service model that's going to be embedded in this community center. And so I'm conducting interviews and collecting surveys from youth, caregivers, and staff at all different levels of the organization and volunteers. So trying to gather multiple stakeholder perspectives on what the needs are in this community, what the needs are in the Clarkson Community Center, what are the barriers to promoting mental health, to engaging with families effectively, what do they see as the opportunities for meeting those needs, et cetera. And we're going to take those results and again, through collaboration with this community advisory board, we are going to bring together research evidence and practice-based evidence, or kind of setting specific evidence to think about what kind of service model is going to be ideal for this specific setting, and think as well about how we can bring this kind of process into additional settings so that we can continue to maximize feasibility, acceptability, and fit, as well as meet the needs of different settings and take advantage of the opportunities in those settings, while also infusing evidence-based supports to build positive adult-youth relationships, supports for parenting, and then supports around high-quality training and supervision. So we're building out broadly, again, a stepped care support model. So at the first tier of this model, all staff and volunteers are going to receive training and ongoing support in culturally responsive trauma-informed care, in positive interaction support strategies, and in the identification of some mental health and academic concerns. And just, simply like, what do you do when you do see a young person or a family member who you think might need more support? And if you do find one of those kids, then you can connect with a liaison who are going to hopefully be introducing into the community center. And this is going to be somebody who can connect with young people and their families when they're identified as maybe being in need of more supports, to assess mental health and academic concerns, to provide emotional support, psychoeducation, and interventions, as well as connect to wraparound services needed. And regarding those specific interventions, there's a pretty rich literature on paraprofessionals being able to implement a number of interventions. And so we'll be aligning with what those are. And then if kids or families are really in need of more significant and specialized mental health services, the kinds of services that they might find at a more traditional agency or clinic, then the liaisons will be positioned to counsel those families on their different options, refer to partner agencies, and provide a warm handoff. And then they can stay connected to the kids and families and maintain regular communication to promote continued engagement in services. We'll be applying a variety of principles and tools of clinical science, certainly embedding a problem-solving framework both at the service model development and individual service levels. Thinking about how we can integrate research evidence, setting-specific evidence, and person-specific evidence to customize interventions for each young person or family member. And in order to do that comfortably, we're going to be developing concrete practice supports. So that can look a number of different ways. Here I have an example from a project I worked on in the past in which we created handouts that paraprofessionals could either use for themselves or hand off to parents around a number of parenting topics. But it can look a lot of different ways. And again, we'll be developing those collaboratively. So as I said, at the moment, we're in the middle of this needs assessment with a variety of stakeholders at the Clarkson Community Center. We're then going to be piloting this stepped care model at the community center, and I'm hoping as well with Catholic Charities and New American Pathways. They have also voiced interest in the work that we're doing and want to get on board, which is exciting. And then following formative and summative evaluation and quality improvement work on this model with all of these different organizations, we'll be in a position to scale this model to additional community-based organizations and communities.
So what do we need, right? How can this journey be supported? We're thinking legislation, of course, legislation that supports the funding or expansion of funding to community-based organizations to pilot youth and adolescent innovative evidence-based mental health programs. Many of these things were already mentioned by Darlene, the importance of having qualified interpreters, the importance of hiring culturally competent providers or having people who are culturally competent to provide these services to our community, the training materials that will be needed, as well as the important persons, the liaisons who will help connect these families. And one thing I just want to point out, the stressors have been increasing as we see what's going on within our economy. And the fact that we're providing a lot of these direct services, we're able to see a lot of these, and it's coming down to our children, right? For example, when I spoke about the food pantry, currently our fast scheduled pantry about one Saturday ago, we completely emptied our shelves. We had no food left. We had children asking to, having to complete these intake forms with their parents because they didn't read or speak English, or because the languages that they spoke were not provided. They needed additional supports outside of food, of course, but just having that one support, or being able to get this one support from one central location to which many of those families walked to the community center, that was the key. And so, just imagine what could be done if we could fund more projects like this at a community level, basis. Thank you for the presentation. And do you have any questions?
I do have one question, and I really appreciate the presentation. And by the way, I did go through Clarkson and get coffee at Refugee Coffee Shop. The latte is really good. I do have a question about the training. Do you include in the model training of university students in the graduate schools, like in psychology, social work, education?
Yes. I often, the way that I'm envisioning having graduate students, so I work in the clinical psychology training program. So I'm in a PsyD training program. And so I have graduate students who I plan on training to be consultants. And so they can scaffold the training and the ongoing support of the folks in the community-based organizations. I really do want to make, oh yeah, please go ahead.
I was gonna say, so that's part of the model?
It's not something that I've articulated as a specific part of the model because I wouldn't want that to be something that got in the way of replicating this model in a space where there weren't graduate students to provide that consultation. But I think there are also a number of ways, you know, like at the moment, Mercer is looking for additional opportunities for practica for graduate students. And so when we talk about having culturally competent kind of psychology providers, it would also be possible that our students could step into that role if we can find somebody to supervise them for it. And again, I wouldn't want that to be an explicit part of the model because I wouldn't want that to be the factor that kept it from being applicable in a space where those supports weren't readily available. But I think a lot of what we're hoping to develop is a process for creating a model that can be adapted for different settings.
It would seem to me that since we have a number of entities vying for a limited amount of funds from the legislature, if you know, we certainly have a workforce issue, and if you could use the fact that you are actually training future psychologists, social workers, whatever you're going to have there, to try to sell your plan.
Yeah, that's helpful.
Are there any other questions? I appreciate all these wonderful talks. Each time we've had one of these meetings, I learn things about things that need to be improved. And tonight was no exception. And you know, they're just as deserving as anybody. And especially I was taken aback by the fact that these are not illegal aliens, as people like to say. These are people who are here legally, and yet they're not, they don't have access to the services they richly deserve. So certainly, that did not escape me. Well, I thank you, everyone. And on that note, have a good night.
Thank you.